Okay, I think it's time. Okay, we're going to go ahead and get started just to be mindful of everybody's time. As people are joining, they can just go ahead and join in when they are ready to join. So without further ado, welcome everybody to this amazing webinar that we are going to be discussing today. So before we begin, I wanted to give a brief introduction about the Women's Fund. So my name is Jennifer Ramirez, and I am the Senior Program Coordinator for the Women's Fund. And the Women's Fund, we're a nonprofit here in Houston, and what we do is our mission is to provide women and girls the tools they need to be advocates for their own health. And so we do this through focused seminars, curriculum-based classes, and publications, all which are free of cost. And today we are having a great conversation which was approached by the Fibroid Institute of Houston. So I do want to say a huge shout out to Melissa and to Riley for making this possible for us to be here today. So huge thank you, which I wasn't aware of, but this month is Fibroid Awareness Month. So before the end of the month, we wanted to bring some light on this very, very important topic that many women face every single day. So thank you so much. Today we have Dr. Mott and Dr. Fischer, who will be joining us today. So brief introduction for them. The Dr. Wanda Mott. She is the Medical Director, Women's Specialist of Houston at Texas Children's Hospital, Assistant Clinical Professor at Baylor College of Medicine. Dr. Mott is a board-certified obstetrician and gynecologist with over 20 years of experience in the Texas Medical Center. She leads one of the nation's premier programs for comprehensive women's health care and specializes in minimal invasive procedures, including laparoscopy, hysterectomy, and robotic ablation. So she is widely recognized for her leadership in medicine and community service. Dr. Mott has received numerous accolades, including Top Doc and Super Doc. She has served as a speaker and panelist for local and national women's health conferences, including the VET Foundation Women's Health Symposium. Dr. Mott has chaired multiple public health initiatives, including the Western Area Health Committee of the Links, Inc., and Safe Motherhood programs providing clean birthing kits in sub-Saharan Africa. She is also active in health equity work through organizations such as the NAACP, the Mary Susan Moore Medical Society, and the Women's Fund. Actually serves for our board. At a Phi Beta Kappa and Magna Cum Laude graduate of Smith College, Dr. Mott earned her medical degree from Baylor College of Medicine, and she is a proud Houstonian, wife, mother of 6, and lifelong community advocate. And then we also have Dr. Fischer. So Dr. Fischer attended Baylor College of Medicine, did his residency at the University of Washington, and his fellowship at the University of Texas MD Anderson. He is a former associate professor of radiology at Baylor College of Medicine. He performed one of the first UFEs in Houston in the year 2000 and has since performed over 3,500, 1,000 of other minimal invasive procedures, and over his 20-plus year career. He has also been instrumental in making the UFE available to women in Houston and Southeast Texas. After being on staff at Baylor St. Luke's Medical Center for over 20 years, Dr. Fischer opened Fibroid Institute Houston, the first dedicated UFE outpatient treatment center in Houston, and he takes pride in offering personal approach to treating women in uterine fibroids. Treating fibroid patient in this dedicated outpatient setting allows him to provide quality and effective care to his patients. So as you can see, we have the best of the best here with us today. But without further ado, let's go ahead and get started. So I will pass on the mic to Dr. Mott.
Fantastic. Well, good afternoon, everyone, and welcome to Fibroids. Why me? And I am Dr. Wanda Mott, and I'm going to talk to you about fibroids. It's a very common, and we can start with the first slide, please. Okay, it's one of the most common lesions that one can have in the uterus. It's a totally benign mass, and it may not cause you any problems at all. There's a picture there, and that little white ball that you're seeing is attached to the uterus, and you can see that it's muscular, and certainly it grows in a whirl of muscle, and it can actually destroy some of the normal uterine muscle. It's a very, very common tumor, but it is benign, and millions of women deal with these fibroids and the growths associated with them on a regular basis. Next slide, please. So everybody always wants to know what's the cause of fibroids. They don't know the cause. Certainly, we know that certain things can influence them. We know that hormones, particularly estrogen and progestin, can oftentimes cause them to have greater growth. Certainly, we know that certainly familial presentation can also make you have a greater possibility of having fibroids. But honestly, 40 to 80% of women will have fibroids. And usually it's in the reproductive years that we will see that there will be some presentation. Certainly, once you go into the menopause, often the fibroids that women have or difficulties that they have with fibroids go away as the uterus shrinks. And certainly the hormone levels, the estrogen and progestin that come from your ovaries actually go down. Next slide, please. Certainly, what are the symptoms of fibroids? Everybody that has fibroids, when you go to your doctor and you have your well woman exam or pelvic exam, they may notice on the exam that there may be some variance in the shape or the size of the uterus. But unless it is extremely large or depending on the position, you may not have any symptoms at all associated with it. But the most common symptoms that lead you to treatment are excessive or painful bleeding during the periods. And the bleeding can be extreme. It can be associated with some fullness or bloating in the abdomen, as well as the masses increase in size. Certainly, a mass that is taking more space in your pelvis will press on the bladder and the rectum. So oftentimes there may be problems associated with emptying the bladder or problems associated with emptying the colon, as they all three, the uterus, the bladder, and the colon, are taking up the same space. Next slide, please. So what are the symptoms associated with having uterine fibroids if they make a difference in your day-to-day life? Certainly, painful intercourse may be one. Low back pain. When we talked about the fact that the fibroids may take up more space in the pelvis, then there may be constipation or pressure on the rectum, especially at the time of the cycle. There may be an abnormally watery discharge. Everybody has some form of discharge, but it may be more excessive associated with fibroids, especially fibroids in the cavity or coming through the uterus. Certainly, the increase in the abdominal distension or enlargement of the abdomen can be certainly very similar to pregnancy related to the growth of the fibroids. Next slide, please. What are the risk factors? Are there any things that make you at more risk for fibroids? The biggest thing, and the one thing in the center, is family history of fibroids. Usually there is a predisposition in families. Your mother, your grandmother, your aunt, your sister, many of them will have had, not necessarily knowing that they've had fibroids, but have had very heavy periods. The periods have been excessive. They learn that this is something that they normally do. And so people get used to having very excessive periods. But the normal blood loss with a regular menstrual period is 1/4 cup of blood. Most of the ladies and that's for the entire cycle. Certainly, most of the ladies that have fibroids and have difficulty with them will have excessive bleeding. They'll go through a pad or a tampon within an hour associated with their bleeding. Certainly, we know that ladies that are obese have a higher incidence of having larger fibroids. Ladies that have an early onset of their menstruation, that's before the age of 10, and those that have a late onset of their menopause, that's after the age of 55, they also have a greater risk of having fibroids. And we see that low vitamin D is also associated with this. When you look at the obesity, you look at the menstruation time, you look at the menopause, all of those are related to hormone production. And we know that excessive estrogen production can lead to growth associated with fibroids. Next slide, please. Certainly, what are the complications that one can have related to having uterine fibroids? Just because you have them and they are benign tumors doesn't mean that you need to do anything about them. What is important is, are the fibroids causing you any pain? Is the pain something that goes away easily once your cycle starts, or is it something that is totally unmanageable or unbearable? When you see your provider, you can certainly talk with them about any unusual cramping, because certainly everyone has a little bit of cramping as the cycle starts. But usually it's not anything that stops you from your normal activities. You're able to go ahead and play sports or do your work or whatever you're doing without any problem. Certainly fibroid pain, because it is the contractility of the uterus around that hard area, oftentimes it's incapacitating pain. You're at home in bed using a heating pad and other things, doing a hot bath, a hot shower, and still the pain is coming through. Certainly swelling in your abdomen can be a complication because the uterus is expanding into the abdomen. And the most important thing to remember is that the bleeding can be excessive, and that can lead to very severe anemia. Certainly, many ladies have had difficulty or found out that they had fibroids when they were trying to achieve pregnancy. They are unable to achieve pregnancy and find that they perhaps had fibroids in the lining of the uterus, or fibroids that were blocking the tube or blocking the portion of the cervix, and they were not aware. Certainly, you can go into pregnancy with fibroids. There can be some associated difficulties as well. This can include having a premature pregnancy, premature labor. It can also include variations in bleeding, and certainly fibroids are estrogen dependent, and they grow associated with the amount of estrogen that they are exposed to. Certainly in pregnancy with the placenta, you have thousands of times more estrogen circulating. So we can have growth in the fibroids in the pregnancy. They can cause increasing pain, and certainly there can be almost a competition between the fibroid growth and the fetal growth depending on the placement. And we have seen fetuses with what they call small for gestational age, which is a smaller size baby because the fibroids are competing for some of the blood supply as well. Next slide, please. Certainly, how are fibroids diagnosed? Well, most of the time, like I was saying, they're diagnosed with your routine pelvic exam. Your provider or your doctor will notice an irregular, in the normal uterus is about the size of a Bartlett pear. So it's a small organ that sits in your pelvis and doesn't usually cause you any problem. Certainly, if you have fibroids, which are extra pieces of muscle that are attached to the uterus, they can be on the surface of the uterus, they can be in the muscle wall, or they can be in the lining, but they make the contour of the uterus, instead of being that smooth Bartlett pear, something very irregular. And that irregularity may warrant your provider or your doctor evaluating further. They may ask for an ultrasound, a sound wave study, where they're able to see the lining of the uterus, certainly the shape of the uterus itself, and also if there are added masses. Then MRI, which is magnetic resonance imaging, actually allows us even more information about the fibroids and anything that is inside of the uterus or in the pelvis as well. Hysteroscopy is a visualization of the lining of the uterus. Remember, I said the fibroids could be on the surface, they could be in the muscle wall, or they could be in the lining. Fibroids in the lining will often interfere with implantation and problems associated with achieving pregnancy. So a telescope-like instrument can be taken through the vagina, through the cervix, to visualize the lining of the uterus and determine if fibroids are there. And certainly laparoscopy, which is a telescope-like instrument while you are asleep, through the navel, to visualize the outside surface of the uterus as well. Next slide, please. So can you treat fibroids? Do they always have to have something done? If they're not bothering you, certainly you don't really, because they're benign masses I talked about, they just need to be followed by your doctor. So oftentimes your doctor will have you come in to see them maybe twice a year or once a year, depending on the growth. Certainly, if you are having more pain, then there are over-the-counter medicines that you can take. Ibuprofen, naproxen, those types of medicines, certainly Tylenol, usually will help any pain associated with very small masses. Certainly, if there is anemia, then iron supplementation may be certainly warranted, even iron infusion if it is excessive. Certainly, low-dose birth control pills or low-dose birth control, whether it is in an intrauterine device, that is a progestin-only device that can stay inside of the uterus for anywhere from 5 to 8 years to decrease the heaviness of bleeding, and certainly the cramping is available. Certainly, birth control pills themselves, intrauterine devices, certainly NuvaRings rings or a combination estrogen and progestin rings in the vagina also can be utilized to decrease the heaviness of the bleeding, decrease the cramping, and certainly the pressure and pain associated with fibroids. Now, there are what they're called GRNH agonists. And these are drugs that are honestly designed to drop the estrogen level. Remember, fibroids are estrogen dependent, and they actually help to decrease the blood flow to the fibroids and result in small amount of shrinkage. Usually, your provider will use those right before you're having some surgery because it decreases the size of the masses and allows the dissection for the fibroids to remove them if you are having them removed, certainly to go easier. That most common drug that people hear about is a Depo-Lupron. This is a drug that can be used for that. Other oral therapies certainly are Orlissa or an Egolix, which is a drug that can be used for 24 months at a time to decrease the heaviness of the bleeding. This is oftentimes used in ladies that have developed what is called profound anemia. It allows their menstrual periods to actually disappear. They go away for a while and gives them a time to get back to their regular cells because they become so anemic and they're not needing to be transfused over and over. They're able to make their own blood. It takes 21 days to make a red cell, so it takes a while for someone that has a very low hemoglobin and hematocrit, which is your blood level, to get it back to something that is normal. But it gives you time to make a decision on what type of therapy am I going to need for this if it's going to be a long-term problem for me. All right, we've talked about different ways that one can handle this without any surgical intervention. What happens if the fibroids get so big or they're giving you so much trouble, you're having so much bleeding that we're going to have to do some surgical intervention? Or if the GRNH agonist or the other medicines, the Orion, the Orlissa, these drugs that are designed to stop the bleeding are not taking care of what we need to have done. Next slide, please. Then we're talking about surgical intervention, and there are lots of different surgeries. Everybody does not need surgery who has fibroids. Certainly, if you are having problems with obtaining or actually having a pregnancy, if you are having incapacitating pain and it cannot be treated in the manners that we discussed, certainly if you are having profound anemia and the bleeding cannot be controlled in some of the manners that we discussed, then we're looking at surgery. If you're interested in maintaining your fertility, then we're talking about a procedure that's called a myomectomy. Fibroids are myomas, so we're removing the myomas from your uterus. There are multiple different ways that this can be done. Next slide, please. And the myomectomies can be done. We talked about the hysteroscope before, which is that telescope that goes into the lining of the uterus where you can visualize the lining. You can also go into the lining and remove fibroids that are in the cavity. That is extremely important in those ladies that are interested in pregnancy because the fibroid cannot occupy the space that the fetus should occupy in the pregnancy. Other modes of myomectomy would be laparoscopic myomectomy, which is a minimally invasive procedure where a telescope-like instrument is placed through the navel, the fibroids are identified and removed through the laparoscope. And then the fourth, if the masses, and we talked about masses that could get excessively large, they would be certainly causing pressure on the bladder, on the bowel, and causing you markedly increased bleeding. These may have to require an opening of the abdomen, which is called the laparotomy. And those fibroids can be removed from the uterus and the uterus reapproximated. So all of this is designed in myomectomy to allow you to achieve pregnancy. Next slide, please. Now, the final thing is that certainly there are ladies that have been battling fibroids for many years, and they are now deciding to move on to definitive therapy for that. That would be hysterectomy, which would be the removal of the uterus, and hysterectomy for the uterus only. For the fibroids, the ovaries and tubes may stay in place, and certainly that person would not go through any menopausal-like symptoms associated with that if they were not in the menopause. Certainly, uterine fibroid embolization is a procedure that Dr. Fischer is going to tell us all about, and the ways that we can avoid major surgical procedures in doing another minimally invasive procedure. And then there's radiofrequency ablation. And this is really designed for very small fibroids, not those that are very, very large, but it actually ablates the fibroids in the muscle itself. So that's a kind of an idea, okay, of what fibroids are, how they're treated, what the problems are associated with it. But I want to turn it over now to Dr. Fischer so he can talk to us about uterine fibroid embolization. Thanks, John.
Thank you, Wanda. I really appreciate that. I welcome the opportunity to do this. So I'd like to thank the Women's Fund for the opportunity to speak today. Also, it's always a pleasure to speak with, participate in a program like this with Wanda. She and I have been working together for, 20 plus years now, and have shared a lot of patients over the years. So that makes it even better, especially on the second to last day of Fibroid Awareness Month. So I think Dr. Mott did a wonderful job of giving some background about fibroids. I'd just like to touch on a couple of other things and reiterate a couple of things that she said. But fibroids are extremely common. They're just benign muscle tumors of the uterus, and they have a major burden on the healthcare system throughout the country, with an estimated $30 billion annually in treatments, complications of fibroids, and lost workforce and productivity for the patients. It's estimated that as high as maybe 70, maybe even 80% of all women will have fibroids, but fibroids do disproportionately affect Black women, and as high as 50% of all women with fibroids become symptomatic. I think Dr. Mott pointed out quite nicely that just because fibroids are present doesn't mean that we treat them. I like to tell patients all the time that if they're not bothering you, we don't want to bother them. So we only treat patients who have significant symptoms. Hysterectomy is kind of the mainstay, or the traditional treatment for, and the most definitive treatment for uterine fibroids, removal of the uterus, and it is actually the second most common surgery performed in the U.S. Just in regards to women seeking options, and the good news is that there are multiple options available for treatment of fibroids today, many of which weren't available even 10 or 20 years ago. So more options for patients are always better, but patients in general have shown the desire to have additional options because about 40% of women with fibroids seeking treatment for fibroids see at least 2 gynecologists and wait an average of 3.5 years for treatment. And that's because they don't necessarily always like the first options that they're given. So next slide, please. A little bit of history about UFE, or uterine fibroid embolization. UFE, or embolization, is simply a fancy medical term that means cutting off the blood supply to something. So we'll talk a little bit about how the procedure is done in more detail, but basically what we're doing with the UFE procedure is going inside, cutting off the blood supply to the fibroids, and causing those fibroids to shrink and die. This procedure is relatively new. It was reported first in France in 1995, and it was kind of a serendipitous discovery. They were actually treating patients with embolization, and trying to shrink the fibroids prior to a patient undergoing myomectomy or surgical removal of the fibroids to make the surgery safer and easier and reduce blood loss. And the way that the healthcare system there was set up at the time, there was a significant wait time between the embolization and the surgery. And so a lot of the patients weren't showing up for their surgeries. And when they called these patients to find out why not, many of them said, well, my symptoms are better. And so that's kind of how so many great discoveries over the years in medicine and other forms of science have been kind of, we've kind of fallen into. And that was, UFE was one of those. So it's kind of discovered accidentally. So they started looking at UFE as a primary treatment option for fibroids. The first case actually report out of the US was at UCLA Medical Center in 1997. I did my first case here in Houston in 2001. And, you know, like all new procedures, there was some difficulty early on in getting it recognized, especially by insurance companies, and getting payment and making it available to patients. I was involved very early on here locally in all of that and contacting medical directors. And really that gate didn't completely open until 2008, when we finally had enough data about the procedure to prove that it was not only safe but also very effective in properly selected patients for the treatment of fibroids, of symptomatic fibroids. And ACOG actually recognized this in a practice bulletin published in August of 2008. Next slide, please. So sometimes, the procedure is referred to as UAE, or uterine artery embolization. They're not exactly the same, but for the most part, the terms are used pretty much interchangeably. Next slide, please. So, like all procedures, really the foundation for good outcomes is patient selection. We want to make sure we're offering the patient, the procedure to properly selected patients. So, as Dr. Mott pointed out, there are multiple options available besides UFE, different types of minimally invasive surgery, medications. The good news is there are a lot of different options, and not one option is is best for every single patient. It depends on a lot of different factors. Next slide, please. So what kind of things do we look at in trying to make the determination as to what the best option or options are for any given patient? Well, we look at multiple things, but some of the most important are the number of fibroids in the uterus, the size of those fibroids, the location of the fibroids, the blood supply to the fibroids, and then there's some patient-centered aspects to it. The age of the patient, whether or not the patient desires future fertility, what, if any, prior fibroid treatments that they've had, what other medical conditions that they may have. And then one very important component is some social considerations, like, is the patient a primary caregiver taking care of an elderly, parent, or a special needs child? I mean, there are certain patients that for whatever reason just can't spend the time to recover from an open surgery, even if that may be the best option. Next slide, please. So, as Dr. Mott pointed out, the vast majority of fibroids are initially diagnosed by physical exam with some abnormal irregularity or masses within the uterus. But soon after that, usually the first step in imaging of fibroids is pelvic ultrasound. That's kind of the mainstay and the most common imaging performed for fibroids. It's widely available. Most gynecologists have it available, and many other physicians as well have it available in their office. It is relatively quick and expensive. However, the downsides to ultrasound is that it's very user dependent. It depends on who's doing the scan, how they move the transducer, how they're measuring. And it's really one of those imaging studies that you have to be present for to get the most out of. Just still images later on are helpful, but not near as helpful as being there for the actual scan. It also provides limited tissue characterization and blood flow information about the fibroids. So next slide, please. So in our practice, prior to UFE procedure, we require a pelvic MRI for all patients to determine for sure if they're a candidate or not. So MRI has been used more and more commonly for imaging of fibroids. It's not as readily available, so it's not available in every office. It tends to be significantly more expensive and time consuming than ultrasound. So those are the downsides. However, there's less user variation, therefore more reproducible results. It's not as subject to who's doing the scanning at the time. It provides for better tissue characterization, which by any imaging study, we can never be certain what anything is, 100% by any imaging study short of getting tissue, but it does provide some evidence for there are certain characteristics that fibroids follow on the MRI, that if they follow those characteristics, we can feel quite certain and quite comfortable that they are in fact a fibroid versus something more ominous. It also provides information about the blood flow to the fibroids that is very difficult and many times impossible to obtain from ultrasound alone. Next slide, please. So, as I mentioned, why do we require pelvic MRI? We talked about the better tissue characterization, the vascularity. That does require IV contrast. It can also make diagnoses of things that are very difficult to diagnose by ultrasound, like uterine adenomyosis, which is a very common benign condition that commonly occurs with fibroids and can cause symptoms identical to fibroids. It's a little bit of a simplification, but it's basically like an endometriosis of the muscular wall of the uterus. It's better at visualizing ovarian pathology. So many times in large fibroid-filled uteri, the ovaries can be very difficult to see with ultrasound. On MRI, it's very uncommon for us not to be able to visualize them. So we need to make sure that they look normal as well. And it also better defines the exact size, number, or location of the fibroids, which, as I mentioned, are very important in trying to determine what the best treatment options are. So this is an example of a sideways or sagittal image looking at the uterus, which is this area at the top of the, just above the bladder there. And this particular fibroid, which is that dark area in the middle, with ultrasound, it may be difficult to tell where it lies. Is it in the wall? Is it in the cavity? Is it part and part? By the MRI, it's pretty clear that the majority of this fibroid is sitting out in the cavity, and that could make a significant difference in what treatment option is chosen for a patient and or what the approach to that treatment option may be. So next slide, please. So the UFE procedure has evolved over the years, but it is now the majority of UFEs are being done out of the hospital, actually in surgical centers or office-based procedure. It is a minimally invasive image-guided procedure. There are no incisions or sutures. It's done under deep IV sedation. It doesn't require any intubation or general anesthesia. And basically what we do is we place a small catheter into an artery. We usually use currently we're using mostly the radial artery, which is a tiny puncture into the artery in the left wrist to access the arterial system. The other option, and the more traditional option, is the femoral area. We do procedures both ways, and we kind of leave that up to the patient. But regardless of the way that we access the arterial blood supply, we place a small tube or catheter into the artery, and we use an X-ray camera over the top of the patient to guide that small tube into the blood supply feeding the fibroids. Most of the time, that's the uterine arteries, and most women have two uterine arteries, one on the right, one on the left side of the pelvis, and it's important to treat both to get the best possible outcomes. And once we have the tube in a position within the artery, as you can see in that cartoon picture at the bottom of this slide, and we're comfortable with that position, we inject these tiny little, what we call embolic particles, and these particles get carried by the blood flow into the smaller and smaller branches of the arteries feeding the fibroids until eventually they reach a tiny blood vessel that is smaller than they are, and they get stuck, and they're too big to go forward. People ask me all the time, do they circulate in my body? They do not. It's like you're pouring them into a strainer. So they get caught inside the tiny blood vessels within the fibroid or fibroids, and they block off or plug up all these blood vessels, and that's how we shut down their blood supply. And then once the fibroid has no blood supply, it's not getting the oxygen and the nutrients and everything it needs, it shrinks and dies over time. It does take several months to get the maximum benefit from the procedure, which is one of the potential downsides. It's not an overnight thing, but the bleeding symptoms, especially the heavy menstrual bleeding, usually responds very quickly, which makes sense because that's what we're attacking is the blood flow. And was not the case when I first started doing the procedure, but today this procedure is covered by all of the major health insurance companies. So next slide, please. So as I mentioned, we use either radial or femoral access. The procedure on average takes about an hour to do. We use a deep IV sedation. In addition to that, really the primary, challenge to this procedure over the years has been some of the pain that it can cause afterwards. Many patients, not all, but many have significant menstrual type cramping after the procedure. And this has been challenging to control at times. So one of the things that we're doing now that's really been a big step forward in pain control and overall patient comfort and recovery is that we're doing a hypogastric or regional nerve block during the procedure, which really offers significantly better pain control than we were able to achieve with just medication. So because of that, we're no longer having to keep patients in the hospital overnight. We're able to send them home within an hour or two of the procedure, and most go home pain-free. After the patients leave the office the day of the procedure, they have very few physical limitations other than how they feel, but the average complete recovery time for most patients is about 1 week. And the bottom picture on this slide shows the tiny little puncture in the left wrist with what we call a TR band or a pressure bracelet on it after the procedure. And then we just slowly release the air, the pressure in that bracelet, and remove the bracelet before the patient goes home. So next slide, please. So a little bit more about the embolic particles that we inject to cut off the blood supply. There are two that we use. There are many others out there on the market, but these two have been shown to work the best and have the most data and to support their use. So there are embospheres and PVA or polyvinyl alcohol. Both of these are approved by the FDA. And perhaps even more importantly, they've both been on the market in the US for a long time, over 20 years each. They've been shown to be equally effective and they're very safe with no long-term effects reported. I've never seen, heard about, or read about any adverse effects of having these inside your fibroids or inside your body. Next slide, please. So why does it take a week for patients to feel back to normal? Well, there are some symptoms that are very common after the procedure, and we refer to these symptoms collectively as the post-embolization syndrome, which is just a fancy term for the body's natural response to cutting off the blood supply to the fibroids. It's an inflammatory process. And so when patients immediately after the procedure, they typically have, as I mentioned, some pelvic pain or menstrual-like cramping. They can have fever, usually low-grade fever, sometimes associated with hot flashes or night sweats. Their white blood cell count, which can throw some people off because it can be a sign of infection. It doesn't mean infection in this case. It is known to cause an elevated white blood cell count for about a week or 10 days after the procedure. Most patients have general malaise or just kind of general fatigue, lower than normal energy levels for a few days. Some may have some nausea, especially the first couple of days after the procedure. A little light vaginal spotting, bleeding, or discharge is common, and constipation as a result of some of the sedation and medications that we prescribe are also common. But all of these symptoms gradually improve day by day, and usually patients, they're, like I said, back to normal, and symptoms are mostly gone in about a week's time. So next slide. So what are the expectations after we do a UFE? Well, the average reduction in the size of the dominant or the largest fibroid is about 50% in volume. The average, and because the uterus is enlarged because of the presence of fibroids, as the fibroids shrink, the uterus will also shrink. So the average reduction in the volume of the uterus is about 40%. But that's only really half of the equation. So a lot of people focus a lot on the size, which is very important. But the other important component to this is that the fibroids also change in their composition. So fibroids are made of muscle tissue, which is a very heavy, very hard, very dense tissue. And a lot of the symptom relief that patients get is the fact that not only does the fibroid shrink in size after embolization, but also changes in its composition. It changes from that heavy, hard, dense muscle tissue to like a spongy, residual scar-like tissue. And it's the combination of those two changes that lead to symptom relief in the majority of patients. So bleeding symptoms usually respond the most quickly, usually the first month or two or first cycle or two after the procedure. Most patients notice a significant difference in that their cycles are either much lighter and or much shorter than before. And that makes sense because that's what we're attacking is blood flow. The bulk symptoms like the urinary symptoms, the pelvic pressure, back pain, constipation, those types of symptoms tend to take a little bit longer, on average of about 2 or 3 months before patients notice an appreciable difference. And then all the symptoms can continue to improve over the course of several months. Most of the changes within the uterus and fibroids occur in the first 6 months after the procedure, but the fibroids can continue to shrink and change even up to a year after the procedure. Overall effectiveness is about 94% for bleeding symptoms and a little bit lower at about 90% for bulk symptoms. And patient satisfaction rates are also very high. Next slide, please. So what kind of follow-up do we do after the procedure? Well, our routine follow-up visits are at 1 week, 1 month, and 4 months post-procedure. Of course, we see, patients at any other time after this that they may have some questions or any concerns. And then we only repeat the MRI imaging if a patient's still having significant symptoms at 4 months. We used to repeat imaging in everybody, but MRIs are quite costly and time consuming. And so if a patient's symptoms are better, as I tell patients all the time, we're treating the patient, not the pictures. But usually there's a strong correlation in how the patient's doing and what the pictures look like on the MRI. So we're only repeating MRIs now if the patient's still having significant symptoms or problems at that 4-month mark or around that 4-month mark at this time. And that's fortunately a minority of the patients. So next slide, please. So what are potential risks? Well, there are risks with everything. This is no exception. Overall, the risks are very low, but the procedure can cause an early or premature menopause. It's an age-dependent risk factor. So the closer a patient is to menopause, which is usually early 50s, the more likely it is to kind of accelerate that process into menopause. Infection after UFE is extremely rare, even without any antibiotics. And for that reason, many that do this procedure do not even provide preventative or prophylactic antibiotics. We still do because I feel like that there's very little downside in doing so, and we want to reduce that risk of infection as far as we can. Anytime you put a tiny catheter into a blood vessel, there's a theoretical risk of bleeding or damage to the vessel. Fortunately, knock on wood, that's never happened to me, but it has been reported. We do use ultrasound imaging and x-ray guidance for everything, so everything is done under direct visualization. Some patients, although rare, can develop a chronic vaginal discharge. It has to do with the way that the fibroid degenerates, and that can be quite bothersome. Sometimes that resolves on its own, but sometimes it doesn't and may eventually require surgery. And then the final risk we worry about is of an allergy to the contrast or x-ray dye that we use during the procedure to find our way through your blood vessels, through the patient's blood vessels. So it's an iodinated contrast. It's the same type that they use for CAT scans or CT scans. So. But those are the things that we worry most about. Next slide, please. So one of the most common questions I get are, can I get pregnant after a UFE procedure? And are there any additional risk of pregnancy after UFE? Well, the shorter answer is yes, and we don't know for sure. So we know it's very possible to get pregnant, have a normal pregnancy and a normal child after a UFE procedure. It's been reported hundreds of times in the medical literature and probably thousands more patients, including a number of my own patients over the years that have not been reported. But there are some unknowns. So nobody knows for sure what, if any, additional risk the UFE procedure may cause. Increased risks of infertility, complications of the pregnancy. There've been some, case reports here and there both ways, but there's never really been a good prospective study performed. And I'm not sure that there ever will be because there's so many variables involved in that. But so we don't know for sure. No one's ever proven for sure there is higher risk, and no one's ever proven that there aren't higher risk. So we always counsel patients in that regard and really leave it up to the patient because I feel that, it's kind of their decision on what to choose as long as they know what we do and what we don't know. So we choose patients on a case-by-case basis. The size, number, and location of the fibroids really comes into play. So if a patient, for instance, has, just a couple of fibroids and they're easily accessible surgically, especially if it's through a minimally invasive laparoscopic surgery, as Dr. Mott had referred to, or hysteroscopic surgery, then that's probably the best approach. But patients like in the picture I've included on this slide that have so many fibroids, just tiny fibroids really just throughout the uterus, it would be impossible to remove them all surgically. These types of patients are the ones who really have very few options. And so this may be where UFE plays a role in at least trying to provide them some relief without having a hysterectomy and losing all hope of future fertility. So next slide, please. As I mentioned earlier, there's a condition known as uterine adenomyosis. I included it here, even though this talk is not specifically about adenomyosis, but I included it only because it so commonly occurs with fibroids. As I mentioned earlier, really the only reliable way to diagnose it with imaging is by MRI, and it's one of the many reasons we require an MRI because it does change our approach to the procedure slightly, and it requires some additional counseling of the patients who are still, wanting to have embolization despite the presence of adenomyosis with their fibroids. So the reason why adenomyosis is important is that we know embolization works very well, like 90+% of the time for fibroids. It still works pretty well, but not quite as well for adenomyosis. So rather than 90+% effective, it's only about 75% effective, which means that 1 out of 4 patients, despite, changing some of the ways that we do the embolization procedure to maximize success, still have persistent or recurrent symptoms. So again, that's just something we like to counsel patients ahead of time, and so that they can make their own decision. And the only definitive therapy for adenomyosis is a hysterectomy. Next slide, please. And I also want to mention that sometimes we get asked to do preoperative embolization by some of our referring gynecologists who, we may have a huge fibroid that, especially for myomectomies, which can be associated with significant blood loss during the surgery because of the vascularity or the amount of blood flow to the fibroids. So we get asked to embolize the fibroids to take away their blood supply prior to doing surgery, and or to reduce the size of the uterus, sometimes to even change the approach of the surgery from, a larger incision to a smaller incision, or sometimes even going from an open surgery to like a robotic or laparoscopic type surgery. So that's something that we're asked to do on occasion. If the goal is to minimize bleeding, the surgery can be done very, very soon after the embolization, usually like 3 to 5 days. Or after, even beyond that if needed, but they can be done that quickly. If it's for debulking or reducing the size of the uterus of the fibroids, we usually wait quite a bit longer, about 3 to 5 months. So next slide. So overall, what can you expect from us, and what should you expect from anybody doing this procedure? Well, we offer very compassionate, personal, concierge level care for our patients. Most importantly, safety is first. Safety is king. If it's not safe, we're not going to do it. We want to select patients properly, and that goes for any procedure. It's all about patient selection, making sure that we get the best outcomes for patients. We offer a lot of flexibility. We have several office locations all over town. We offer telehealth visits. We collaborate and communicate very effectively with not only our referring physicians, but also our patients. And then, of course, do routine follow-up and make ourselves accessible to patients. And with all of that comes excellent outcomes. So next slide. Again, I really appreciate the opportunity to speak today, especially, like I said, the second to last day of Fibroid Awareness Month. This topic and this procedure has always been, while I've done a lot of things in my career, this has kind of always been what interests me the most. And I tell patients all the time, the reason I enjoy doing what I do and the reason I devoted my entire practice to this procedure is because it works so well for the patients that we choose to do the procedure on. And it's very gratifying to see patients, get the relief that they're looking for, after many of which have suffered for months or even years at a time from their fibroids. So with that, I really appreciate the opportunity, and I think I'll be open-ended, as I'm sure Dr. Mott would be, to questions.
Yeah, so thank you so much, Dr. Fischer and Dr. Mott, for offering this amazing information for us today. Now we are open to questions. I believe you have access to the Q&A or the chat option if anybody wants to go ahead and ask any questions. If not, we have a few questions. So while we allow others to type in their questions, Kenya, would you like to ask a question?
Yes, good afternoon. I'll be asking a few questions to get started. This one is for Dr. Mott. What are some early warning signs of fibroids that patients commonly overlook or misattribute to other conditions?
There are a lot of things that patients overlook. A lot of times people are, they're used to having very heavy periods. I think I can't reiterate anymore that a normal blood loss with a menstrual period is about 1/4 of a cup of blood for the entire number of days that you're having the cycle. Not additive, but that's all of it. Many women with fibroids use 3, 4, 8, 10, okay? They change pads and they doubly wear pads and tampons. That is not a normal period. And certainly women need to be aware of that. Oftentimes they have cramping or discomfort. They use a heating pad. Their mom has always used a heating pad. They've always had to go home and go to bed with their cycles. They've always been like this. And this is something that people traditionally learn. This is part of being a woman woman and having a cycle. But normally your menstrual cycle should not stop you from your normal activities. You should be able to do whatever you normally do on a regular day. You notice that you have your cycle. It doesn't interfere with your daily activities, whether it be sports or work or school or whatever. If it's starting to do that, then that's an indication that you need to see your physician and talk to them. Many times people will have pain, they'll have bleeding, but they'll also have fatigue. They're unable to do their normal activities because they're so tired associated with your cycle. That oftentimes is associated with anemia, and it needs to be actually evaluated by their physician. So anything that's not your regular day-to-day activities, you have to cut back on what you normally do because of your cycle needs to be evaluated.
Thank you so much for the valuable information. And then one more for Dr. Fischer, but you're more than welcome to pitch in as well. What challenges have you faced with insurance coverage or reimbursement for UFE, and how are those being addressed?
Well, so early on, there were a lot of challenges prior, especially to 2008. And as I said, I was involved very early here locally. I remember spending hours at a time on the phone with medical directors from insurance companies and sending them papers and data and trying to make this available to patients. So, but fortunately today, we have very few, if any. It's widely recognized as a viable option for patients. Like I said, I don't know of any major insurance company that's not covering the procedure. Again, if it's indicated, we have to have a reason to do it. So, but today it's well covered. And I did want to just touch quickly on the last question for Dr. Mott. The other thing that I've noticed in a lot of patients in terms of their symptoms is that many patients' sense of normal gets readjusted, especially for the bulk symptoms, the things like the urinary symptoms, the pelvic pain, pelvic pressure. It sneaks up on patients so slowly over time that they don't even notice that they have symptoms. It also happens with the bleeding, but it's less common because, if a patient's bleeding a lot, that usually gets someone's attention. But with the bulk symptoms, especially their sense of normal, I like to tell patients it's kind of like when you haven't seen, a relative for a year. It's easier to recognize that they've gained weight or lost weight or got a haircut or whatever. But if you see them every day, it's harder to notice those changes.
Wonderful. Thank you so much for the information. And this one's really for both of you. Are there current outreach efforts through OBGYN's primary care or community clinics to improve early detection and diagnosis on fibroids?
I think that certainly throughout the city, okay, and certainly through right now, we do have the availability for well woman exams in multiple different facilities throughout the city. Certainly here at Texas Children's, we have outpatient physicians, we have the Baylor, we have multiple different facilities that are available, and then we have satellite clinics as well. But we have to start with the basic well woman exam, going in to be evaluated by your provider, whether it's a mid-level provider, a nurse practitioner, or your physician, and just making sure that your exam is done and that exam is done on an annual basis. What happens is people will have their exam 1 year and then skip it for 3 or 4 more years. And during that time, things have shifted and things have changed. They've noticed their periods are a little bit longer, a little bit heavier. They've noticed that they have a little bit, and they think maybe they're gaining weight. Okay, they have more of a little abdominal girth or a fullness, and it turns out that they have a mass, okay, in the pelvis. But it's really important for people to go regularly to their doctor and to the same doctor, if at all possible, so that they're examining you over and over and they can tell the changes.
Yeah, and I'd like to add, I think it's all about patient education. Patient education has always been important to me. It's one of the reasons we hardly ever, if ever, refuse the opportunity to speak to, women's groups and get the message out. It's all about, there's so many patients that I see that were like, I've been having these symptoms for, 5 or 10 years, but I never knew it was related to fibroids because I didn't know what kind of symptoms fibroids caused. So it's all about educating patients on what type of symptoms and, about fibroids, what kind of symptoms they can cause. So when they start having those symptoms, it may, entice them to be more likely to go seek, further evaluation by their physicians. And then the second level of that is the education about the treatment options available, because as I mentioned, there are so many different options available today that weren't even available 10 or 20 years ago. And so the good news for patients is that there are more options. More options are always better for patients. And as I mentioned earlier, not one option is best for everybody, but not everybody is aware of or being told about all of the options. Unfortunately, there are, in my opinion, far too many, healthcare providers out there that only talk about those things that they do. And I think in many ways that's an injustice for patients, because I think it's important. And so many patients are given only one or two options. They don't like either. So then they do nothing. And for fibroids, that's, if you're having symptoms, that's probably the worst thing you can do, because the bigger your fibroids get and the bigger the uterus gets, the fewer options you have available. So the sooner that patients seek treatment when they start having significant symptoms, the more options they typically have available to them.
Thank you. And just for a second time, we have one last question. So what, if anything, can be done about fibroids during pregnancy?
During pregnancy, we like to make sure that we've evaluated before pregnancy. I really want to put that out. Certainly that patients need to, before you plan a pregnancy, you need to come in and see your doctor to get an assessment, of your health status, just across the board, not just the uterus. Where are you with your blood pressure? Where are you with your blood sugar? Where is everything related to your health? Because pregnancy is a very stressful state. Certainly women do very well with pregnancy, but we have to start at a certain level. And it's so important that women come in and they get their initial evaluation. We need to plan this. We need to get on prenatal vitamins. We need to have an appropriate diet. You need to plan it when a time that is not a very stressful time in your life. You need to not be traveling all over and having multiple different jobs, okay, and responsibilities, when perhaps you might need to cut back some during the pregnancy. So making sure that your stress level is not excessive, okay, when you're planning a pregnancy is very, very important. But we don't remove fibroids in pregnancy. They have a tremendous vascular supply. The uterus gets a quarter of your entire blood volume goes to the uterus every minute, okay, in pregnancy. So there is a tremendous amount of blood flowing. So certainly if you have achieved a pregnancy with fibroids in place, then we try to work through that with you and making sure that the fetus does well, that you do well, that your blood loss associated with the fibroids is minimal. Certainly fibroids are very vascular, as Dr. Fischer has been saying, and certainly we talked about the tremendous amount of bleeding that can come associated with it. Just think about the growth of those fibroids in the pregnancy, along with the pregnancy, and what type of blood flow that would actually require. And certainly making sure that the patient is not, okay, a victim of excessive blood loss associated with that. And also that the fetus grows normally, because certainly in pregnancy, fetal growth restriction is something that often can take place. As well as premature labor, there are a lot of complications that can be associated with pregnancy. So I would really, really stress that having an evaluation by your provider before you achieve pregnancy is so important. But if we don't get that, then seeing the provider regularly so you can get an assessment on fetal growth, on the fibroid growth, on any discomfort or pain or unusual discharge that you're having during the pregnancy will be vital.
Okay, well, thank you so much for that information to both of you. If anybody has any questions, and maybe you think of a question later on today, feel free to reach us at healtheducator@thewomensfund.org, and we will make sure to get your answered question by either Dr. Fischer, the Fibroid Institute, or Dr. Mott. I would appreciate it so much if we received your feedback on today's webinar presentation via the survey link, the QR code. We would very much appreciate your feedback. just a little promotion for the Women's Fund at the end. Follow us at our social medias. We are available Facebook, Instagram, Twitter, and of course, this presentation will be uploaded to our YouTube channel. So if you want to go back to it, just give us a few weeks to be able to get it up on our YouTube channel. And yeah, I appreciate both of you for being here with us today with this valuable information. And if we can take away anything, is please be advocates for your health. Please speak up. Please seek your doctor. We are in charge of our own medical decisions. So please make sure that if you are concerned, you're asking the right questions and you are doing these checkups that are so, so important on an annual basis. So thank you so much, Dr. Mott and Dr. Fischer, for participating with us, for being here with us today. We appreciate it very much. And I hope everyone has a great rest of your week. And yeah, hope to see everybody in the future events.
Thank you.
Thank you very much, Jennifer.
Thank you.
Of course, thank you.
Thanks,
Thank you.
Thank you.
John.